A very
Just
good evening. Yeah, did it
just a
start?
second. Yeah, no. Just a second. It is loading. Um, yes, we are live.
A very good evening to all the respected doctors present here. I, Dr. Snehal from the USC Medical Team, welcome you all for yet another interesting session. The topic of today's chat show is pioglitazone and optimizing diabetes care and NAFLD. As we know that non-alcoholic fatty liver disease has become the leading cause of liver diseases worldwide. In India, the prevalence of NAFLD is approximately 30%, but in patients with diabetes, prevalence is almost double and reaches around 60%. In today's meeting, the doctors who are joining us have a vast clinical experience related to these chronic conditions. And in this chat show, we will be discussing about NAFLD and diabetes and the role of pioglitazone. Without much ado, I would now like to introduce to you our esteemed moderator for the evening. We have with us Dr. Rakesh Maria, sir. Thank you so much, sir, for joining us today. Sir is a senior consultant physician and diabetologist at the National Heart Institute, Sukhmani Hospital, New Delhi. With this, I would now like to introduce to the esteemed speaker for the evening. We have with us Professor Dr. Abdul Hamid Zargar, sir. Thank you so much for joining us today, sir. Sir is a senior endocrinologist at the Center of Diabetes and Endocrine Care, Gulshan Nagar, Srinagar, Jammu and Kashmir. He is formerly a member of Medical Council of India, past president of the Endocrine Society of India, member of the Institute Body AIMS New Delhi, chairman Department of Endocrinology, Director and ex officio secretary to Government Steady Cosmet and Institute of Medical Sciences, Srinagar. Thank you so much for joining us, sir. With this, now I hand over the session to our moderator to take it forward with the opening remarks, followed by which the talk by Dr. Zargar.
Thank you, Dr. Snell, for those kind introduction. And at the outset, I'd like to thank the USV team for giving us this opportunity to be amongst you all. And it's a proud privilege to be moderating a session for Professor Zargar. And well, friends, as we are all aware, and we are very well aware, in fact, all the guidelines also stress upon the usefulness and the importance of achieving a good, tight glycemic control to reduce the risk of both micro as well as macrovascular complications in a diabetic patients. We physicians today are really spoiled for choice. We have a whole lot of drugs available to us which are at our disposal to manage our glycemic control. The TZDs, the drugs in the group, the pioglitazone, the only drug available from the TZD group were introduced in the 90s, and their usage expanded rapidly. But of late, due to certain associated risks, especially the risk of heart failure, their priority position in the treatment of algorithm is going down the world over. But nevertheless, still the use of TZDs with newer therapies could play a very, very important, significant role in attenuating the risk factors of metabolic syndrome. They still have an important role to play in the management of diabetes and its associated comorbidities. And today we have with us Dr. Zargar. He'll be talking to us about the usefulness of pioglitazone and its therapeutic benefit in management of diabetes and metabolic dysfunction associated steatotic liver disease, that is NAFLD. NAFLD is now has been now relabeled as MASLD. Over to you, Dr. Zargar, for your presentation.
Thank you, Dr. Maria, for your affectionate introduction. Very rightly, Dr. Maria pointed that what we used to call as initially fatty liver or non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, over the last 1 decade, it has become amply clear that it is fundamentally a metabolic disorder. I still remember when I became an endocrinologist, we had hardly any imaging tools available at us. And when initially these ultrasounds came and people started saying that there's some fat in the liver, we presumed that fat being everywhere else in the body, because then, 2-3 decades back, this epidemic of obesity started engulfing us. We did not understand much about the pathophysiological importance of this fat in the liver. And in fact, that was the time when hepatitis was so common in the whole subcontinent, particularly hepatitis B and later on hepatitis C. And they used to be the common cause of liver dysfunction, liver failure. Now today, the commonest cause of liver disease, the commonest cause for liver transplant globally is this metabolic dysfunction associated steatohepatitis, what Dr. Maria very aptly put it. That's how it is now being recharacterized. Metabolic dysfunction associated steatohepatitis. Now, in the next 20-25 minutes, what I'll be talking about, my perception of magnitude of this problem, what is the data available, and what are the therapies that are available with us today, and what is the evidence in favor of those therapies. Now, what does an NAFLD mean? Now, starting from the left, where there is a liver, and there might be a globule of fat here and there in the liver, but when you have a fatty infiltration of the liver around 5%, and there is no suggestion of a hepatitis-like picture, then you call it NAFL, non-alcoholic fatty liver. But when the cellular architecture starts getting disrupted, hepatocyte degeneration, what I mean, a hepatitis-like picture, and there are memory bodies and mega mitochondria, which indicate a dysfunction of the hepatocytes and early fibrosis, then we call it non-alcoholic steatohepatitis, or in the current nomenclature, metabolic dysfunction associated steatohepatitis. Means steato refers to the content of the fat, which is now much beyond the 5%. And also hepatitis means the liver enzymes have started getting elevated. As this hepatitis-like picture progresses, this progressive liver damage will lead to fibrosis. And over a period of time, as this fibrosis proceeds over a period of months and years, it might be significant enough to lead to cirrhosis and some cases of hepatocellular carcinoma. Now, if you look at it today on your right side, there are many components of this metabolic disease of the liver, but two situations that are commonly associated with this disorder are obesity and diabetes, either independently or together. Now, this is a data that depicts the trends of obesity globally in the last 40-50 years. And this is a paper that was published in Lancet May 2016. And it represents how obesity has been doing from 2075 till 2014 globally, including India. We have been a part of this study for a long time, more than a decade, looking at how these non-communicable diseases are globally evolving, and huge amount of data from our country. Now, if you look at this slide, look on your left, obesity in men. In 1975, in terms of absolute number of obese individuals, we had 19th highest male population of obese people. What conversely that would mean that even smaller countries like France, Italy, or even Ukraine had more obese people than us, males. Now look on your right side. What was the picture in 2014? We have the 5th highest number of obese men in the world. just after China, United States, Brazil, and Russia. So it means in these 4 decades, obesity has been slowly going up and steadily going up. And if this was the situation in men, this is the situation in women. In 1975, Indian women also constituted the 19th largest population of obese women for a country in the world. Again, you can see many smaller countries, Ukraine, Germany, Italy, France, had far more obese females. But today, we have the 3rd highest number of obese women in the country after China, United States, and India. So you have an important cause for this fatty infiltration into the liver in our own patient population, in general community and patient population. Now, second important cause, or probably the most important cause, diabetes, how diabetes has been behaving. This is data published the same year how diabetes trends have been from 1980 to 2014. And this paper also got published in Lancet the same year. Now look at this. On your left side, number 2 is India, which says that in 1990, India had just 11.9 million diabetics. And when the study was published, 2016, and the last data submitted for analysis was 2014, India had 64.5 million diabetics, from 11 to 65. And today, the same figure has reached 101 million in the just around half a decade. So again, another huge population which is likely to have a propensity to have this fatty infiltration in the liver. As I was just now telling you, NAFLD is the most prevalent chronic liver disease today, and it affects 1/4 of the world's population and 1/2 of the diabetic population. 1/2. Indian data shows that 56% of type 2 diabetics have some amount of abnormal fat in their liver. And by the year 2030, the hepatitic part of it, NASH, which is relatively more aggressive than just fatty infiltration, will increase by 63% by 2030. Continue the leading cause of liver transplantation, globally as well as in India. This summarizes it all. Look on your extreme left. Obesity, abdominal obesity, you have all the components of metabolic syndrome, insulin resistance, dyslipidemia, diabetes, prediabetes, prehypertension, and hordes of other metabolic dysfunction associated with this central adiposity. If a person's beta cells are robust, he only develops non-alcoholic fatty liver disease. And this non-alcoholic fatty liver disease independently has a potential of causing cardiovascular disease and macrovascular complications. 1. Second, as I alluded to in my previous slide, if it leads to fibrosis, then you have a potential of having a chronic liver disease, which can decompensate in any stage, lead to cirrhosis, or more so, lead to hepatocellular carcinoma in a smallish group of people. But if beta cells cave in view of this insulin resistance and metabolic syndrome, then diabetes would set in. Then again, with uncontrolled diabetes, microvascular complications would occur, macrovascular complications would occur, depending on the magnitude of this obesity, metabolic syndrome, insulin resistance. Both of them might coexist, as I said earlier on. Unfortunately, most of the cases of so-called fatty liver are asymptomatic. Just people who have obesity, who have distance, need to be seen and evaluated for that. And few people might complain of some vague fatigue, lassitude, asthenia, and some discomfort in the right upper quadrant if there's a significant or huge hepatomegaly. And in most of the instances, the diagnosis is made incidentally. So you get a barrage of, you get a serum chemistry done, in that LFT is also coming in. So you certainly found out LFT is deranged. SGOT, SGPT are grossly elevated, or you get a ultrasound done or imaging of the abdomen done for an unrelated cause. And suddenly you find you have a fatty infiltration of the liver, and then you try to quantify that fatty infiltration of the liver. Normally, how do we investigate it? Ultrasound is today available everywhere. It's non-invasive, and we have a huge number of sonologists now. This investigation is now reasonably inexpensive, widely available, and is non-invasive. Fair accuracy in moderate to severe hepatic steatosis. But the operator variability would always be there depending on the competence of the operator who does it. But what is the most important tool we use in today's world? What is known as vibration controlled transient elastography. This also is a form of a sonography where you look at the elasticity of the liver. And when you have a fatty infiltration, its elasticity is different, it's more stiffer. If you have fibrosis, it's far more stiffer. So this is the classical, what we call as fibroscan. And there are certain limitations in this. If somebody has morbid obesity, huge obesity, those guys who are 120, 140 kilos, BMI of 45, 40, or huge ascites, liver decompensation might be difficult. But by and large, this is a tool that we have been using for quite some time. Sometimes we use MRI-related investigations, which is, again, non-invasive, very good at quantifying the hepatic steatosis and has excellent reproducibility and can help in staging the magnitude of fibrosis. But understandably, at mass level, doing an MRI is going to be costly. But in people, where there is any ambiguity, this tool can be used. This is a tool that has recently been developed. We haven't yet worked with it in a very big way. AD has recently recommended it because when you talk about 50 to 55% of type 2 diabetes having fatty liver, how often do you subject them to these investigations? An investigation has to be non-invasive and cost-effective, and something that can be done on a regular basis. Because it's not that somebody has yes or no fatty liver today. We don't have to look at it a year later or 6 months. We look at creatinine once in a while. We look at urinary proteins once in a while. We get a fundal examination done. We get a cardiac examination done. So in a similar fashion, this another tool, and it is sensitivity and specificity I'm not very sure about, but you only need age of the patient, you need SGPT values, you need platelet count, and then you can formulate it. And I'm sure in the next couple of years, we'll start experimenting with it and find out whether it predicates at what is suggested today. This tool might be used to get a rough idea which are the guys who need to be more extensively investigated, because you cannot extensively investigate 60% of our patients because it costs us money, it causes discomfort, and being away from work, away from family. And this might ultimately help us to find out relatively smallish number of people who are not only having a non-alcoholic fatty liver disease, but who have a non-alcoholic steatohepatitis, which would be a relatively smaller subset, not that 65%. It will be around 10 to 15%, which need to be that intensively investigated. as I was telling you, the magnitude of this problem is getting worse by the day. This is a recent data published in that study, the national study about diabetes prevalence in the country. And you can just look at it. 101 million diabetes, 136 million pre-diabetes. They have an equal predisposition. Dysglycemia, 236 million. And look at abdominal obesity, 351. So you can imagine what sort of numbers in real term we are looking at for investigating. So that's where we need tools that simplify diagnosing non-alcoholic fatty liver disease, looking at the progress of that and identifying that subset which is liable to progress to a chronic liver disease. What are the recent recommendations from optimally? We do once in a while evaluation of the kidneys. Are kidneys okay? There's a protocol for looking at cardiovascular dysfunction. We need to have a look at the eyes and fundus once in a while. So now progressively we're looking at, now in a similar fashion, we need to look at liver. And liver enzymes and this 4 score that I was talking to you about, with which we need to still experiment with how reliable it is. Because if it is a reliable tool and is a non-invasive tool, it'll be something like by a app calculating an EGFR. So that might simplify our life. Dr. Rakesh did tell you just now about Pioglitazone. It has gone through a tumult ever since it has come to the market. Coming in with a bang, had some roadblocks, coming again, then some roadblocks, and now reappearing with a new bang. Pioglitazone or glucagon-like peptides, receptor agonists are the preferred treatments of hyperglycemia in adults with type 2 diabetes and who have a biopsy-prone steatohepatitis. And there's a reason for that, and there is a level of evidence that they would help is A. It means they're significantly. In adults with type 2 diabetes mellitus and non-alcoholic steatohepatitis, glucose therapies other than pioglitazone and GLP-1 receptor agonists need to be used wherever they are indicated. And I will tell you their role in possible remission of steatohepatitis in the coming minutes. And this is the trend-setting study. This paper came in New England Journal of Medicine in 2006. Look on your left side. Pioglitazone reduced liver fat. Placebo on the extreme left, and look the second one, this one here. Before pioglitazone and after pioglitazone, significant loss. And these are healthy controls. This is a placebo and this. And another study where it shows that yes, insulin resistance is broken down. Currently, pioglitazone is the only diabetes medication included in the recent guidance from the American Association for Study of Liver Disease to treat patients with biopsy-prone NASH with or without type 2 diabetes mellitus. So this is the data from that. Meta-analysis of some of the studies related to pioglitazone and fatty liver have reconfirmed that yes, they do reduce the fat content in the liver and can be used as a first-line therapy for non-alcoholic fatty liver disease. Now, on top of that, if you look at pioglitazone, I would say over the decades, ProActive trial is one of the most important trials on which, from which a lot of data on pioglitazone has come in. I showed a slide when you get a non-alcoholic fatty liver disease, you may or may not get diabetes, but chances of your patient getting a cardiovascular disease, macrovascular disease is pretty high. Now look at this. In this study, more than 5,000 type 2 diabetic patients with a prior cardiovascular event were randomized to pioglitazone or placebo, and the study continued for 3 years. Now you see, if you look at MACE endpoint, there was the hazards ratio of 0.84, means there was 12% reduction during the follow-up period in 3-point MACE. And look at in people who had a myocardial infarction, recurrent MI in diabetic patients with previous MI who received pioglitazone, hazards ratio of 0.72. So it would mean that subset of population who were on pioglitazone for treatment, literally there will be 28% lesser reinfarcts. So that is something that we need to look at. In people who had a stroke, another component of the macrovascular disease, if they are given this pioglitazone during follow-up period, there was a huge 47% reduction in second stroke. So again, saying that this is apart from whatever it does to the liver, it has cardiovascular benefits. And this is the meta-analysis of randomized trials and looking at macrovascular disease and look at the hazards ratio reduction, HR 0.75, and data on about 6,000 people. Again, proactive trial. IRIS trial, this was done on almost 4,000 guys who had insulin resistant state but did not have frank diabetes, had an ischemic attack, transient ischemic episode, or a stroke-like sickness. They received pioglitazone, and look at placebo and pioglitazone, significant reduction in the events, later events. Now, secondary analysis from the IRIS, 29% relative risk in coronary arteries, acute coronary artery syndrome. And in a similar fashion, massive reduction in MI and massive MI. Now, all said and done, if you look at diabetic population who have this fatty liver, so not only what you directly do for the liver, it is also important to control diabetes well. Because, see, the way we say if you reduce hemoglobin A1C by 1%, this will be the decrease in possible nephropathy and retinopathy, macrovascular disease in particular. So in a similar fashion, every 1% increase in mean hemoglobin A1C was associated with 15% higher odds of increased fibrosis, thereby meaning if you reduce this A1C, this progression can be retarded, slowed down, maybe even reversed. And fibrosis progression is almost 70% higher in patients with type 2 diabetes mellitus than non-diabetics, as happens in obesity or otherwise. So if hemoglobin A1C is controlled well, probably the progression of this NAFLD to NASH to chronic liver disease to cirrhosis would be diminished, slowed down, or may not occur in a big chunk of people if that hemoglobin A1C of less than 7 or 7 is achieved very early. So controlling diabetes is also extremely important. Many drugs have been postulated to control diabetes as well as help non-alcoholic fatty liver disease. There are huge data on SGLT2 inhibitors. One paper came from one of our own young colleagues about empagliflozin reducing the liver fat. Many people believe that any drug that reduces the central adiposity may also reduce this ectopic fat in the liver. Some data available on canagliflozin, some data available on empagliflozin and other glyphosins, but not yet going to the level where, guidelines would strongly recommend it. Yes, GLP-1, particularly data on liraglutide and axinatide. You can see on the left side, JCM paper, half a decade back, reduction in the fat after using liraglutide and after using axinatide. DP4 inhibitors, some studies published in Hepatology about 7-8 years back, yes, might cause some reduction in the fat. And now today, this program sponsored by the USV reputed concern, they're creating a combination of pioglitazone and vildagliptin in the management of uncontrolled diabetes and fatty liver. We did talk about the pioglitazone component, but look at the data that was again published quite some time back in JCM. Vildagliptin treatment showed significant reduction in intrahepatic triglycerides and reduced SGPT level over 6 months. The reduction was independent of any weight change. But authors have also given a caveat that if somebody's liver enzymes are more than 2.5 times the upper limit of normal, then caution should be observed. But this also means that use it strategically in time, use it early. Probably the benefit of two drugs can be combined, not only trying to put brakes on that non-alcoholic fatty liver disease, but also optimizing hemoglobin A1C in those guys who have insulin resistance and beta cell dysfunction. And there's some data that has been recently created, not yet published, where people were divided into 3 groups. One group gets vildagliptin and pioglitazone. Another group gets vildagliptin alone, and third group gets pioglitazone alone. And what does the data show? And what we look at? We look at hemoglobin A1C. We look at what is happening to fasting and PP blood sugars. We look at the safety like hypoglycemia, fluid retention. So a possibility of a heart failure. And now look at it here without getting, looking at the time profile. Understandably, people who were getting a combination of this therapy, pioglitazone and vildagliptin fixed dose, had a better glycemic control and tolerability than one alone. Understandably, when you use a gliptin and a strong insulin sensitizer, it would give a better glycemic control than one product used alone. You can see hemoglobin A1C 8.2, 6.9, and you can see how combination has gone down to, and look, pioglitazone alone, vildagliptin alone. In a similar, I don't think this is a huge brainer. This will tell us. And this also tells us that, looking at the enzymes, how the hepatic enzymes also are getting proportionately lower in this population where you use 2 of these drugs, and also in the pioglitazone group alone. So by and large, in a very early stage, because late stages, vildagliptin alone may not work, pioglitazone vildagliptin combination could be a reasonable therapy for managing type 2 diabetes and non-alcoholic fatty liver disease, at least for quite some time, because we know a verified trial showed that if we give a maximum dose of vildagliptin and metformin very early, probably for more than half a decade, half the people would not need any drug escalation. And that would mean if somebody's HbA1c is kept at less than 7 for half a decade, chances of progression of this non-alcoholic fatty liver disease head on towards the steatohepatitis would also come standstill, even from the very early times. What do the guidelines say? Today, unambiguously, obviously, when you have diabetes, when you have obesity, when you have ectopic fat in the body, your liver. So everybody would say that lifestyle is most important. Trying to reduce weight, exercise, and diet, reduction in the macronutrient content in the food, and at least 5% to 10% of the weight loss can be achieved and should be achieved. Therapeutically, as I rated earlier on, Pioglitazone or GLP-1 receptor agonists are recommended for type 2 diabetes mellitus and biopsy-prone NASH. So before I summarize this, so many therapies that we use today are not recommended. Today, so I have seen lots of our friends. In fact, in the past, I also used to use some amount of vitamin D. Much data does not favor this. But yes, Pioglitazone, not in NASH alone, recommended in diabetic NASH prone by biopsy. But yes, as Dr. Maria was telling us, some risk of edema, weight gain, risk of osteoporosis. So that's why it's important at what stage of the natural history of the disease we position it. Saroglitazone are, yes, probably available, approved by the DCJ only, does not have a approval from the FDA, is not available still anywhere else. Some soft data on liver, but Pioglitazone universally accepted as a good treatment in absence of better treatment. This looks a reasonable choice. GLP-1 receptor agonists, yes, good. Most of them are injectable. We have an oral drug available in the country, but cost is quite prohibitive. And I'm sure this area, the area of fatty infiltration of the liver, the metabolic dysfunction related liver disease, will be a focus of attention for quite a few years to come from the therapeutic intervention point of view. Thank you so much. Over to the chairperson.
Thank you, Dr. Zaga, for a brilliant deliberation on the usage of Pioglitazone in management of diabetes and also the NAFLD. We'll stick to the old term as of now, and NASH, of course. And you very nicely highlighted the sudden spurt in the increasing number of diabetics, which were recent guideline, and the ICMR study showed 101 million. But on top of that, the obese people were even more than 3 million. That's a 300 million. That's a huge increase, and it's a worrisome factor because both even obesity alone can be responsible for the steatohepatitis and causing all the problems. And as you rightly have highlighted, and you have very nicely highlighted the usage of non-invasive both scannings and the blood tests, which is the FIB4 for diagnosing these patients non-invasively. And yes, I agree with you. The FibroScan has caught up quite a bit in our country, and this FIB4 and all still needs to be standardized, or seen how it works in our country. With that, I think we can have questions from the audience, and we can go to the chat box. But before that, I would just like to for you to give a general guidelines or guidance to the, because as you suggested, the GLP-1 receptor agonists are very good but not affordable in majority of our patients. Very few of our patients can afford this. Pioglitazone as of now remains perhaps the only approved drug. So for the sake of safety, would you like to give some general guidelines to the audience before initiating Pioglitazone, and what dose would you recommend in the Indian population to be on the safe side?
Excellent question. You see, in younger people, there is no problem. Early onset, if diabetes of a shorter duration, there is no problem. And when I was talking, when we combine this vildagliptin, it means then diabetes has not been probably there for a long time, but because then this alone might not suffice. Then many more drugs would need to be added. If a person does not have a history or suggestion of heart failure, then we need to resist. If there is a postmenopausal lady and we have suspicion of osteoporosis, we need to desist. If there is a history of any cancer, particularly bladder cancer, but here with the caveat, proactive trial retrospectively showed that there was no increased prevalence of bladder cancer in patients who were part of the protocol on pioglitazone. So I think that suspicion has been removed today. So probably only if there has been a suggestion of a fluid retaining state, then we should desist it. If is cognizable osteoporosis, we should desist it. So that's why, if earlier in the earlier stage we use it, probably we can. It's something like, Dr. Maria, you given an excellent control to a guy who is 35 for 10 years. At least you delay the complications by a decade. So in a similar fashion, if you delay this progression of the liver dysfunction for a decade, then understandably better drugs might prevail by then, or you might need better drugs for managing diabetes.
Yeah.
So I would say today, and about the dose, telling you very honestly, I have been a fan of pioglitazone right from the word go. It is the best insulin sensitizer known. I was one person who vigorously fought that it should come back to the market because it's a cheap drug and our poor people need it, and it has amazing results. I'm saying many times you will find, Maria, and I'm sure your experience tells you the same thing. A person may not apparently look obese, that young boy or girl or woman, or that 60 kilo lady or 68 kilo young man or an adult, but you will say significant central adiposity. And suddenly, you break this insulin resistance with pioglitazone alone or with pioglitazone and metformin, sugars come down. And in that class of people, if you have that central adiposity, where those BMIs are not like that horrendous 35 or 40, you will find out those enzymes getting normalized. So that class of people should not be deprived of this drug. 15 milligrams should suffice. Western world had some problems because they used to use 45 milligrams. In India, we never used 45 milligrams. But now, ever since, we are only recommending today 15 milligrams. Yes.
Very true, sir. I think even the Tosca-IT trial where the pioglitazone was compared with the sulfonylureas, and in the subgroup analysis, it was seen that the pioglitazone did have a significant beneficial effect on the NAFLD and the NASH patients, and the dose did not matter whether it was 15, 30, or 45. All of them benefited a lot. And in fact, in our country, when people are using 7.5, even that should be a very safe drug, very safe dose, and a useful one for that matter. And another thing I just wanted to ask you, you just mentioned that this NASH or NAFLD is more than 50% of patients are asymptomatic, and more than that, higher percentage of that do not even have a raised enzyme levels. So can you suggest certain clinical features which make you suspect that you should be looking other than the inadvertently detected fatty livers, in which patient you would like to more seriously look for these problems? Any clinical features or any suggestions for that?
Dr. Maria, if we look at the epidemiology of the non-communicable diseases today, the same study showed in the last 4 years, 4 crore Indians have developed diabetes. On an average age, 29.5. So you can imagine many people would be on the lower side of the 29, maybe 25, 23, 24. Midline would be half, and on the other side would be half. today, time has come that we do not need to wait for a disease to set in. We need to create a social protocol to screen for disease. I'll give an example. Now, for a long time, in our practice, ever since we became doctors, somebody has a fever, comes to you in our clinic or to me. We'll see temperature, we'll see pulse, we'll make him sit on the bed, we'll look at a heart, we'll see blood pressure. Right or not? We might give him an antibiotic, a paracetamol, or a cough syrup, or get a urine examination and an X-ray chest done. But we look at blood pressure because, in a similar fashion, asymptomatic, non-communicable disease is so high in the country today that whenever a person gets an opportunity to see a medical profession, one should be screened for them because we still have an load of undiagnosed diabetes. And when you do not diagnose diabetes, where do we stand in diagnosing a non-alcoholic fatty liver disease? Now, looking at that subset of population where diabetes has been diagnosed and a clinician like you and me is trying to optimize the glycemic control, looking at the morphology of the patient, looking at the characteristics of the patient, finding out how obese he is, how insulin resistant is he, how dyslipidemic he is, how hypertensive he is, we manage his treatment. And over a period of time, we have a defined protocol to looking at his kidneys, heart, eyes. I think now the time has come. We don't have to wait for those symptoms. The way we once in a while look for a proteinuria, the way we keep on once in a while looking at urea and creatinine. Once in a while, every year we ask someone, you have been having no diabetes for quite a while, see a good ophthalmologist and tell him not to just correct the refractive error, but look at the fundus. The way you and me ask people to get an ECG done, and if you have any doubt, we send it to a guy like you and tell him, please do an echocardiography and tell us, does he need any more further vigorous intervention, angiography, further on, TMTs. So in a similar fashion, now the time has come for you and me. Yes, over a period of time, if the body profile is like that, you get and look at the enzymes. Once in a while, look at the ultrasound picture of the liver. And if there is a suggestion of a progressive liver dysfunction or liver dysfunction, seek a proper opinion, get a proper evaluation done. The way we'll, as I was just now telling you, we get somebody has angina, we get an ECG done, we see a lateral wall ischemia, we ask him to see a cardiologist. He gets an echo done, finds a wall abnormality, we ask us for an echo. And then somebody decides whether this fellow needs an angiography or needs a CABG. In a similar fashion, this also needs to be handled once in a while, looking at those enzymes. If you have high index of suspicion, looking at an ultrasonographic picture, and then making your own decision the way we do, like nephropathy. We look at proteins, but a year down the line, we look at it again. We get a kidney function test done today is normal. It doesn't prevent us or dictate us that we will not do it the next year again or 6 months down the line again. Exactly the same protocol is now to be observed in relation to this fatty liver disease. But the only difference is that those protocols for nephropathy, retinopathy, and cardiovascular have been standardized. This is just happening. You are now trying to understand it. Even this FAV4 I was trying to come to grips with. And I'm sure in the next couple of years, we'll have not only a better understanding, but I think we'll have more therapeutic options. Because wherever there is problem, industry is after it to find out a solution. Just look at the diabetes. When I became an endocrinologist, I still remember direct telling me, why are you wasting your 2 years for endocrinology? What is there to know? Dienal, glycophage, and insulin. Now, today you know, and we're all over the, every day you're telling me new things, I'm telling you new things. 4 decades after that. So in a similar fashion, I'm sure you'll be listening a lot about this liver involvement in this metabolic dysfunction over years to come.
So I think we'll take few questions from the chat box as well. Is grade 1 fatty liver required to be investigated further? I think the answer has already been given by you. What do you recommend to screen patients with NAFLD before 35? I think this question, again, you just answered this thing. High degree of suspicion is needed for that, as you just said. Is pioglitazone safe for patients with coronary artery disease without congestive heart failure, sir?
I showed you that I knew this question would come. I put those 3 slides there, deliberate macrovascular disease. It has been shown even in people who had a myocardial infarction. Pioglitazone got caught up in bad times. If it was monopoly, major global pharma would be having symposia on its cardiovascular protective effect. Look at that proactive trial. What it does to people who have had a myocardial infarction. 28, but look at this IRIS trial. You have an ischemic stroke or you have a transient ischemic reduction of a 0.45 hazard ratio, 55% reduction. I'm so like, tell me any drug. Statins don't do that much, 33% reduction. You practice cardiology also, you tell me. You work in a National Heart Center.
Yeah, I think.
Yes, everything has a flip side. You see, we used to give sulfonylureas. Many people would have a problem with hypoglycemias. In my younger days, many people used to tell us that we don't see much hypoglycemia. I used to tell them because you never attempt to control diabetes. You just give a tablet. You don't try to attempt to diagnose diabetes. But it did not desist us. It did not prevent us trying to optimize glucose control when even glibenclamide was only available or chlorpropamide was available. We did not stop it. So in a similar fashion, why do people come to us? Or how do we make a decision? We have a huge armamentarium at our disposal. That's how, when you look at the patient in front of you, the disease pattern, the duration of the disease, the comorbidities, the economic potential of that person. Ultimately, as I just now was telling you, and you recapitulated it about, just say, as GLP-1 receptor agonists. At the end of the day, you or me writing a prescription is meaningless if the patient does not respect it. I'm saying, like, it is not a prescription that we write for pneumonia or typhoid fever or diarrhea for a fortnight, for a month. This is a prescription that needs to be implemented sine die till you and me decide that we need to move on with a better drug. So these are the things that you and me have to decide over a period of time when the patient is in front of us.
Thank you, sir. Thank you for an excellent talk and an excellent answer to all the valid questions which have been asked in the chat box. I believe there are no more questions in the chat box now. With that, I would like to pass it back to the organizers.
Yes, sir. Thank you so much, Dr. Maria sir and Dr. Zargar sir. I express my sincere gratitude to you for taking your valuable time out and helping the audiences understand this complex concept in such a simplified form. Thank you very much, sir. The audiences have greatly appreciated the lecture and they have also actively participated in form of their queries. We are really very grateful to you for giving us this opportunity, for having 2 esteemed panelists like you on board today. Thank you once again, Dr. Maria sir and Zargar sir. With this, we now conclude the session, and good day, everyone.
Thank you very much. Thank you.
Thank you so much. I had a good time listening to Dr. Maria and seeing you and talking to our colleagues. Thank you so much. Had a great evening. Take care.
Thank you, Zargar sir. Thank you, Maria.
Bye-bye. Bye-bye.